Thank you, Dr. Roeker, Dr. Fraietta, Dr. Wiestner. Thanks myself for what I did, Dr. Parikh. I think we covered really a lot of material in Dr. Fraietta, a lot of material in a very short time, and I hope it was accessible. And we have a ton of questions, and we're actually almost on time. So we've taken this long swim, this long journey, this deep dive into CLL from not even, pre-CLL and what that was about, and talking about family relations and what goes on at the beginning, and watch and wait to first treatment, second treatment, third treatment, transplants, CAR Ts, and now into some of the kind of weeds of the new treatments. I want to reassure you that we're going to try to get to everybody's questions, but if we can't get to your questions, we have an Ask the Doctor feature, or send us it on the CLL Society website that we'll try to respond to if we don't get to your questions in this. Also, I want to let you know that this will be archived and up live. There were some audio problems at the beginning, and we'll be retaping that. So the beginning portion will be, at least part of it will be retaped to cover that material again. So without much further ado, I want to get to the Q&A and start with, well, it's hard to know where to start. There's so many great questions. If I'm getting IVIG, can I get a vaccine? If I've had a monoclonal antibody like rituximab or obinutuzumab, is the vaccine going to work for me? Or other medications that say a BTKI, should I wait and hold it for a week to get a vaccine? What do you advise your patients?
Yes, very good questions. So IVIG, I mentioned that for our clinical trials, we had to exclude, but that's not because you would not respond to the vaccine, but because the IVIG brings in antibodies from other people. So this is actually the purpose of IVIG, to bring in immunoglobulins that help you prevent infections. So you can definitely also get vaccinated when you take IVIG. And I would recommend that even if you're on IVIG, you do get at least the seasonal flu vaccine. With rituximab, and maybe to some degree with BTK inhibitors, what we know is that they interfere with B cells and B cell responses. So rituximab eliminates normal B cells for about 6 months after the last dose of rituximab. And that also applies to obinutuzumab, all these anti-CD20 antibodies. So during that period, it is very unlikely that you could mount a response to a vaccine. At least the vaccine response has two arms. One is the one generated by B cells, the other that generated by T cells. But we really think the B cell response is very important, and after rituximab, you would not have that. The same concern applies to some degree for Ibrutinib, acalabrutinib, all the BTK inhibitors. And that's why we did this study with the flu vaccine, where we found that 27% of the patients had a good response to the flu vaccine, which is maybe about half of what you expect in CLL patients not on a BTK inhibitor. So there is some reduction in that memory response we try to achieve with the flu vaccine. With the novel, with the immune system recognizing a new antigen, I think the impact of the BTK inhibitor is even larger.
All right. A recurrent question that circles around this issue is B cells and T cells. Joe, there's a number. First, can you give us a little background science at a patient-friendly level of what B cells do and what T cells do? And one of the concerns is, I'll throw this out to you too, and if you want, you can hand it to Lindsey or Adrian. we've heard about our T cells being fatigued and that being a problem in earlier discussions. Isn't that a problem when it comes to CAR T? Our T cells are kind of pooped out and they're not that effective. And isn't that also a problem, in responding to vaccines or to COVID infections, that we have crappy T cells? And I know that you're giving the BTKs to try to improve it, but it's confusing to me. Dr. Wiestner is saying the BTKs may inhibit response, but you're saying that it helps the T cell. So first start with the basic science. Explain to me the difference between a B cell and a T cell, and talk to me about how they play in the immune system, CAR T, and if you want to touch on the immune response to vaccines, or I can hand that to Lindsey or Adrian.
Yeah, all great questions. So at a very basic level, B cells make antibodies, which we heard a lot about today. And we could think of T cells in the context of at least this meeting as being certain types of them, particularly as being the heavy hitters in killing tumor cells. So we have two very different arms of the immune system, but of course they don't operate in vacuums. So there's a lot of dynamic interplay between T cells and B cells. And I think maybe, Brian, what you're getting at is that some of these therapies that we were talking about affect both B cells as a deliberate target, right, of the therapy, but indirectly they can affect T cells. And that could be either a good thing or a bad thing. Now, in the case of Ibrutinib, which both modulates B cells but also T cells, we found and others found, particularly Dr. Bird's group, who's, he's not here today, but there's a potency enhancing effect of BTK inhibitors, particularly Ibrutinib on CAR T cells, even though it was designed to target the BCLL cells. So I don't think I've answered all of your questions, but I could certainly turn some of it over to my colleagues who are vaccine experts like Dr. Wiestner.
Dr. Wiestner or Lindsey, Roeker, do you want to respond, either one of you, to the issue of the T cell response in CLL to either the COVID infection or COVID vaccines or any vaccines? Lindsey, do you want to start?
Yeah, I think of in general the B cells as being surveillance and the T cells as being security. So the B cells are watching for something bad happening and the T cells are taking care of it if it arises. Obviously, when T cells are fatigued, our concern is always that infections can be unnoticed or be unaddressed. And I think it's a huge question in the setting of COVID because we suspect that the response to any potential vaccine or to clearing an infection requires both B and T responses. So it's a great question. I don't think we have enough data to really know right now, but it's an ongoing area of investigation.
And let me follow up with a question on that. Some of these new vaccines for COVID look like they're live vaccines, but the live vaccine isn't an attenuated or weaker form of the COVID, but it's an entirely different virus that is carrying the spike protein in a different way. Are there going to be the same prohibitions against us getting those live vaccines because we're immunocompromised?
I think a lot of it is going to depend on the specifics of the vaccine. And I think until we know kind of what the initial responses are in non-immunocompromised hosts and how to think about that, we're going to have to really be mindful to ensure that we're balancing response and protection with safety.
All right. And Adrian, on the Shingrix vaccine, if you're taking a cyclovir or valcyclovir to suppress the herpes zoster, should you get the vaccine?
Well, so acyclovir, valacyclovir are very effective in preventing this recurrence, this reactivation of the chickenpox virus that would then cause the shingles. But it means you would actually have to take this forever to prevent this reactivation. The vaccine would mean that it boosts your immune system's ability to keep this virus in check and prevent its reactivation. So hopefully that would actually mean that if there is a protective response, you would not have to continue acyclovir, valacyclovir. The caveat is a little bit, there is no routine testing available whether you had a response. In the general population, the response rate to Shingrix is over 90%. So virtually everybody responds. But in our vaccine trial with CLL patients, we see that the response rate is about 50%, slightly higher in patients who've never been treated, slightly lower in patients on a BTK inhibitor. So it's a little hard then to recommend stopping acyclovir, valacyclovir after you've been vaccinated. But to get the vaccine is safe, and it's been well tolerated overall, associated with these local reactions I mentioned, redness, swelling at the injection site.
Samir, on Richter's transformation, is there anything a patient can do to lower their risk of developing Richter's? Because I don't think any of us want to get it. Is there some suggestion that maybe treating the CLL a little earlier so an aberrant clone doesn't develop? Is there thoughts around that? I've heard discussions about that. What's the current thinking about preventing this rare but serious complication?
Yeah, thanks, Brian. Unfortunately, I don't think that we know enough about exactly what combination of risk factors really will predict the development of Richter's transformation. And I think many of these risk factors are pertaining to the patient's the CLL genetic sort of characteristics, other biological characteristics, etc. And so I don't think, unfortunately, there's a way to manipulate any of those. The point that you bring up where you consider intervening early in the course of the disease process to try and help prevent a more resistant clone from developing, etc., I don't think has been conclusively shown. And I think all of that, is in the context of a clinical trial with early intervention for, high-risk CLL patients. And I think, at this time, I don't think we can really say for sure that, doing anything per se, unfortunately, will reduce the risk of developing, this difficult to treat complication of CLL.
Thank you. Lindsey, I'll start with you on this one. You touched on this a little bit. Telehealth, telemedicine. Do you think it's here to stay? On the line. At some point, this pandemic will ease up, but I think we've learned we can do a lot of things remotely. How do you see it fitting to this, and also into clinical trial design? If you could just speculate on some of that and how you see it working out down the line.
Yeah, fantastic questions. So I think telehealth, you're right, is here to stay. How it's going to fit into our everyday practice, I think a lot of that is actually going to depend on how insurance companies decide to treat it moving forward after this pandemic eases up, like you said. But I think there's still value in coming into an office. Certainly, we can do a lot of things via telemedicine, though there is something about the physical exam, particularly in a disease like CLL, where so much of our decision making is based on a lymph node exam. Certainly, seeing your doctor from time to time is going to remain a very important part of that relationship. In terms of had a lot of flexibility built in the last 7 months as we've transitioned a lot of our regular follow-up appointments to telemedicine for patients on clinical trials. And I certainly think that that will be a part of clinical trials moving forward and will make clinical trials more accessible to patients who don't live near large academic centers. And I think that's a great change.
Joe, thank you. Joe, there was some questions on 17p deletion, TP53. Does that matter to the CAR T cells? And also, we know that a little bit with transplants that the amount of tumor burden you go in with can determine how well you do after an allogeneic hematopoietic stem cell transplant. Is that important with CAR T? Is it important that people go in with uh, not an overload of cancer, though you did point out that people have wiped out pounds of CLL. So if you could comment on the 17p deletion TP53, does that affect how patients do? And I guess, and let me push you even further. Shouldn't we be looking at moving these things up front? I mean, this is, Dr. Leese was talking about transplants. I mean, these are potentially curative therapies or very durable responses based at least with some patients, so talk to us about those issues, please.
Yeah, great questions, Brian. So a couple of years ago, we evaluated the determinants of response and resistance to CAR T cell therapy of CLL, and these CAR T cells were directed against CD19. So many of our patients, and I will caution that it wasn't a large study, so we definitely need larger clinical studies to answer these questions more definitively. But we had many patients, I shouldn't say many, but we had a good number of patients who had 17p deletions, so their tumors were p53 deficient, and they still had complete and durable responses to CD19 CAR T cell therapy. Also, in the peripheral blood, we did not see a correlation between tumor burden and lack of response. You would expect maybe, right, that would correlate. So there was no correlation between tumor burden and response, but I think we have to more carefully look at nodal disease to more definitively answer that. So with respect to
Well,
CAR
we
T
know,
cell,
and I'll interrupt you for a sec there, but we know
yeah,
in
please.
transplants, when the nodes get too big, over 5 centimeters, people have less of a response. So I always thought with cellular therapies, it was important that the nodal disease be somewhat controlled, but that's, I guess, an active area of research in CAR T right now.
It is an active area of research. So the first 3 patients who we treated at Penn back in 2010, 2 of them had complete responses, and they had very bulky sort of lymph nodes and extensive nodal disease. But yes, you're right. That's an active area of investigation. So in terms of using CAR T cell therapy, as more of a frontline option. I think that there are several additional features apart from costs that need to be considered. So many patients, as you know, are quite sick at the time of diagnosis, and the current manufacturing time of CAR T cells is 2 to 3 weeks or more. So that might not be practical, right? And as the severity of what I mentioned as a side effect, the cytokine release syndrome, seems to parallel the amount of disease, that could be too severe, particularly in patients with comorbidities. And finally, as many patients may not achieve complete responses or relapse from complete responses with CAR T cell therapy, I think the big question that we have to answer is, will such patients receive a second or third line course of treatment, and at what cost? And, although we know CAR T cell therapy can really help individuals who have been heavily treated with chemotherapy, little is known about treatment in patients who have relapsed after CAR T cell therapy. So I think there are still a lot of questions to answer. I'm sorry to be a little vague there.
Most of the CAR Ts are targeting CD19. We have some sophisticated patients asking questions here. Are there other targets you're looking at in CLL besides CD19?
Yeah, so we've looked at other targets. One is CD20. Another example is ROR1. CD19, we originally embarked on that because it really seems to be turned on early during B cell development. And so we think there that with CD19 directed CAR T cell therapy that we could hit more, how do I say, the stem-like or progenitor tumor cells, right? Compared to CAR T cells that are maybe targeting some of these other antigens that are expressed later on. So we could maybe eliminate that critical seed population of CLL cells by targeting, a lineage antigen that's turned on early during B cell development, like CD19.
Okay, thank you. Samir, there's been patients who, when they stop their ibrutinib, and I think Mayo's reported on this, have had an aggressive flare of their CLL that can behave a lot like Richter's, even look like Richter's on some biopsies. Can you tell us this phenomena and how do you what's a patient to do in this circumstance? What do you advise your colleagues?
Yeah, thank you, Brian, for that question. I think this is a phenomenon that has been observed in many patients, and I think this is across multiple centers as well, where if a patient is experiencing disease progression on ibrutinib therapy, and this is early on with Dr. Bird's work, where if the next line of therapy isn't decided upon or is not started, then once ibrutinib is stopped, the disease really, quote unquote, takes off. And we've seen many instances where patients have rapid, lymph node enlargement, a lot of constitutional symptoms, their white count really increases, etc. And I think it is important to establish that this is truly CLL progression versus has this transformed into a more aggressive lymphoma like the Richter's transformation we discussed. And I think it is important for a couple of reasons. One is it has obvious treatment implications because you want to know whether what you're dealing with is Richter's transformation versus just CLL progression. And secondly, I think this also is important, especially because pathology of the involved lymph node, etc., may be very important to be looked at. And I think this is where an experienced hematopathologist looking at these lymph nodes to try and determine whether this is CLL progression versus Richter's transformation is important. And I can tell you that there are many instances where there isn't really a uniform sort of consensus between pathologists. So for example, we've seen patients who've been referred to us from other institutions where a diagnosis of Richter's was made, and over here our pathologists don't call it Richter's. They say, well, this is aggressive CLL. And I think this is again an area of active investigation and research that additional data need to be accumulated for us to be able to confidently tell whether this is CLL progression versus Richter's. But I think suffice it to say that this is an important time if you have progression of disease on ibrutinib, that I think getting to the correct diagnosis and subsequent treatment is important.
Thank you. We're going to cover this topic again. It keeps recurring. Lindsey, I'm going to let you grab this one. Can you explain the difference again between reversible and irreversible, or covalent and non-covalent BTK inhibitors in a patient-friendly way?
Absolutely. So covalent BTK inhibitors need to fit exactly in one spot of BTK. So I think of that as like a key in a lock. There only one key fits in, and the lock needs to be a specific shape in order to accommodate the key. Whereas non-covalent BTK inhibitors don't depend on attaching to one spot of BTK. So it's more like a card reader. If you think of like tapping your card on a card reader to open a door, you don't have to hit exactly one spot. You can hit anywhere in that zone, and it'll open the door. So that's how I think about it. It's kind of one spot really hooking on versus not requiring that spot to hook on.
It's pretty clear. Adrian, a practical question. The grandkids have just gotten their mumps, measles, and rubella vaccine. Do I need to stay away from them if I'm a CLL patient? I'm sorry, for Dr. Wiestner?
I didn't hear the entire question, Brian.
All right. If your children or grandchildren have gotten a live vaccine like MMR, do you need to stay away from them as a CLL patient? Because I know they can shed the attenuated viral vaccine. vaccine that's in. If they've gotten a live vaccine, you need to stay away from them if your kids or grandkids have gotten MMR recently.
Honestly, I don't know what the risk really is of that situation. You are recommended not to get live vaccines injected into you. And if one of your household contacts has a live vaccine, I don't know what the risk is of really getting an infection.
Anyone else want to grab that? Or
Brian, hi, this is Samir here. So I can just say that there were some studies done in the pediatric population where siblings of immunocompromised kids who got the live MMR vaccine, there was no evidence of transmission in the immunocompromised sibling. And so in general, it's considered to be safe. But this is extrapolating from kids.
all right. I'm just going to answer a couple quick questions. Can Ibrutinib lead to complete remissions? Yes, it can, but it's rare that it does, but it certainly can. Usually does not lead to undetectable MRD. I'm going to throw the last question to you, Joe. CAR-NKs, can you comment on those?
Oh, sure. Yes. So first of all, NK stands for natural killer cells, and CAR-NKs are natural killer cells that have been engineered to express CARs. So NK cells are a different part of the immune system. As Lindsey alluded to, they're more on the surveillance side. They patrol our bodies for abnormal cells like cancer cells, and they destroy them. So the potential benefits of CAR NK cells over CAR T cells, which I think you're asking about, are the toxicity from the cytokine release syndrome that I mentioned. It's typically lower with CAR NK cell-based therapies. And importantly, CAR NK treatments do not have to be tailored to each specific patient, similar to how T cells are. So the CAR NK cells can actually be cultivated in sort of an off-the-shelf manner. However, I would say that I think that the jury is still out on whether these are as effective as CAR T cells.
And I'm going to just kind of run through a bunch of questions here quickly. And that is there's a question about complex karyotype. Complex karyotype is a poor prognostic marker in CLL, and it's considered in managing your treatment choices. There's differences in the manufacturing processes of a number of the CAR Ts, but right now, at least generally, most of them in the US are targeting CD19. But as Joe went over, there's some looking at other targets that may be developed, and even two targets maybe down the line may be another issue. So we're not going to be able to get to everybody's questions, but please send them in to us at support at CLL Society, or ask the doctor, and we'll try to get to those questions for you. And I need to thank our faculty for generously being available to us for all these hours on a fall morning, afternoon, or almost evening, depending on where you are. I know we have people from all over. I'm so grateful for their time and the quality of the information, and tailoring it towards the patients and answering your questions. We are very lucky to have been supported, and appreciate the generosity of AbbVie, AstraZeneca, Bristol Myers Squibb, Genentech, Foundation Medicine, Janssen, and Pharmacyclics. We could not do a program like this without their help. But mostly I am grateful to the patients and caregivers who attended this. Our motto is smart patients get smart care. And in today's world, we're trying to make access to this kind of smart care available to everybody, whether you live in a rural community far away from a specialist, or whether you live in an inner city and have no health insurance. We're trying to help you, regardless of your gender, regardless of your the color of your skin, your sexual preference, whatever it is. We are here to help you to access the best possible care. All our services are free and we're available to you. So please reach out and let us know what we can be doing to better serve you. Please give us your feedback. It's very important that you complete our event survey. If you liked what you heard from Dr. Fraietta, he's going to have well over an hour to go into much more detail about CAR T therapy, which we gave the provocative name, which he reluctantly agreed to, is can CAR T cure CLL? But I think when you get it 10 years out, you have to be sniffing around the word cure. So you've made it. Congratulate yourselves. We hope you've gained a deeper understanding of CLL and clarity on where you're at in your journey. We hope on this journey from diagnosis almost 5 hours ago to the very latest tertiary care, you're leaving with more hope and more smarts because, as we say, smart patients get smart care. Thank you to the panelists who gave generously their time, our staff, and I want to single out one person. Everybody worked really hard, and we're a small group at the CLL Society, really about a half a dozen of us there working full or part-time. But Liza Average, who's our program director, just worked around the clock to pull this off, and this wouldn't have happened without her putting together lists and lists of lists and reminders and sending us stuff and corralling all the specialists. So we're so grateful to Liza for the work that she did. Also to the On24 staff and the NACE team who helped coordinate this in the presentation and pulled us through some minor technical difficulties at the beginning. This will be archived. Please provide your feedback. You can find it linked in the bottom left of your screen. And we will also email you the survey. We need those results to know how to do this again. Stay tuned. In the website, we'll have stuff on the future of CAR T therapy with Dr. Fraietta. You'd be hard-pressed, as you saw from his talk here, to find a more experienced CAR T expert. And also a number of the speakers that you've heard today, Dr. Bird will be speaking on clinical trials. Dr. K has talked about the early management of CLL. Dr. Mato has talked on MRD. We have a number of speakers talking, including Dr. Bird and Dr. K, on managing COVID reentry. So thank you so much for participating. A special shout out to the caregivers who were involved. And please remember that the CLL Society is invested in your long life. Please support us by investing in the long life of the CLL Society at cllsociety.org/donate. Thank you all. Goodbye. And we managed to finish a few minutes early. Thanks so much. And please give us your feedback. Thanks.